So this is a slide that I made 25 years ago, and I keep updating it. The previous line that we all believed in was that the osteoblast, the OB, was actually the quarterback, and that the osteoclast was the receiver, and it would score the touchdown by resorbing bone directed by the osteoblast. We now know that's not really true, and that this coordination is between the two cells, and the osteoclast actually sends signals to the osteoblast and is helping to direct this very fine synchronization of bone remodeling in which formation equals resorption.
I want to give you some overview on our current knowledge of inflammation impacting bone, and it goes actually back to investigation from 2006 and later also shown by other groups that whenever the body is inflamed, and that can be only a very low-grade inflammation, which you see here, C-reactive protein in the general population, which is sometimes in 1/3 of the population below 1 milligram per liter, in 1/3 over 2.5 milligram per liter, and the other third.
The public health burden of fractures is quite significant. We see it daily here in our offices and in the operating room. It's very common. It's also extremely expensive, over $17 billion estimated in 2005, but $500 billion, up to $500 billion over the next 20 years will be spent on direct costs of fracture care patients. But the actual cost to society and to the patients that we treat is substantially higher due to the pain and suffering that people experience due to the treatment.
So the global objectives of our laboratories, first, is to understand the process of osseointegration at a molecular biologic level. We want to modulate this, hopefully through a number of mechanical and pharmacologic interventions. And then finally, where we're not at yet, but to understand mechanisms of failure of osseointegration as well. For those that don't remember, osseointegration is the concept of having bone directly structurally adherent to an artificial implant. So this is what we do in orthopedics, not only in arthroplasty, but in other fields as well.
The question is, why would nature have all that fat in the bone, opt to use glycolysis where you only get 2 ATP molecules versus 9 that you would get from fat?
So initially, osteoblasts do require fatty acids, and then as they shift into a very rapid mode of laying down collagen, they move to this glycolytic pathway. And so I think we don't know for sure why there's fat in the marrow, but we think that at least in some circumstances, particularly with starvation or fasting, in 10 days in human normal volunteers, we get this huge spike of marrow fat, that this must be a compensatory mechanism that allows the osteoblast to utilize neighborhood energy.